It's a pleasure being here tonight, and I'll be able to be quite at liberty between jet lag and a little bit of fine Australian alcohol. But seriously, I think it's very important that we start framing this in a much wider context. What's happened over the last few years, as people like my colleague Bob Grant, who's here in the audience, started thinking about PrEP, was also the recognition that sexual and gender minority people are truly different than other individuals, may have different health needs. And we're very fortunate in the United States to have an administration that recognizes this, so that PrEP is in a much wider context of recognition that we have a health disparity among men who have sex with men. Globally, the epidemic of HIV is going down in many countries which have generalized epidemics, but it's going up in many parts of the world. Certainly in this region, there are several countries in South and East Asia where rates are going up. Latin America and in the United States, our rates of new HIV infection have not decreased, been about 50,000 new infections a year, with increased percentages among men who have sex with men. And it's not that people are fucking more or necessarily behaviorally disinhibited. There are a couple challenges that we have biologically. Receptive anal intercourse is the most efficient way of transmitting HIV that individuals can do, other than infusion of blood. And with blood safety, anal intercourse is definitely the most effective way that HIV is transmitted. We also have the issue of concentration population pools. So that means that an individual may not be particularly risky himself, but may be in an environment where partners have a high prevalence of HIV. So any new partner falling in love may have consequences for individuals. So we need to frame this not as an issue that has moralistic tones of promiscuity, as much as trying to think of effective ways that people have tools at their disposal to take care of their health. So I'm fortunate to live in sort of a socialist republic called Massachusetts, where we have health reform and marriage equality in a crazy country that's still having a major culture war right now. But we don't see PrEP as the end-all and be-all, but it's part of a package of sexual health. Because we also have to recognize that growing up as a minority in a majority culture means that you're not affirmed in many societies for having different sexual preference, different gender identity or expression. That kind of internalized homophobia has been associated with a lot of other traumatic behaviors, higher rates of depression, higher rates of substance use. So again, this conversation tonight should not be about a pill, but should be about a package of services that we think make sense. And part of the other discussion means how do we educate healthcare providers, because we don't anticipate that every city, every place in the world is going to have a Fenway equivalent. So part of this is trying to have centers of excellence in different parts of the world that are culturally appropriate within those societies that can say, we can show that this can work, that people are not going to be hurting themselves using this intervention. And now it's time for healthcare providers, if they really are about supporting their patients' health, to be fully informed and to have a dialogue. The other issue about PrEP, or whether we talk about treatment as prevention, means that every provider should figure out ways to efficiently ask their patients about their sexuality, their sexual behavior, because sexuality and sexual behavior, as we all know, is quite fluid and is not static. So it's not that somebody needs PrEP necessarily for the rest of their life. And this becomes another important area that we need to explore in the discussion. So I think I've laid out a couple things. You look like you're ready for me to stop, and I will turn the podium over. Thank you.
Let me start by thanking the Victorian AIDS Council and the San Francisco AIDS Foundation for putting on this panel. However sort of scary it also might be to spend sort of half an evening talking about PrEP in front of this sort of eminent and large audience, I might add. I think sort of over the past couple of days it's become clear that PrEP is going to be a major topic for this conference. Those of us who've had a chance to look at the program ahead of time, we're sort of aware of that. And I think it's reflected in the interest here. And Colin reminded us that we typically are quite inclined to think about PrEP in terms of binaries, sort of the bad, the good, and the fine in terms of the new tools and the proven effective new expansion of our toolkits, options, alternatives to condoms, prevention responses controlled by receptive partners, extra safety and possibilities for good sex. And then, of course, there is the other side to that coin, or the other side to that argument, with people sort of emphasizing that we're asking people to take potentially toxic drugs with side effects over the long term that remain to be established. And high cost is an important argument that's being brought forward. Risk compensation. We have erosion of condom cultures, and we have arguments around validating hedonism, and we have, as you mentioned, sort of concerns around resisting virus. And I think my main issue around this binary is that notion is rather artificial, because it's in several senses, and I think the most personal one is that it's not as if there is one camp of people thinking one thing and another camp of people thinking another. And if you're like me, you might think many of those things at one time and the other thing at another time, or you might even think them at the same time. And that's what we call in psychology, we call it ambivalence about those. And in a sense, I think it sort of summarizes my position on PrEP. As I said to Judy, I'm not really sure what I think of PrEP. In a sense, it's an involving engagement with evidence, but also an involving engagement with sort of the possibilities and the challenges in terms of implementing PrEP in practice. And I think sort of my bottom line is that I'm cautiously supportive, in the sense of what Ken was saying. It's not a panacea or a silver bullet. It's part of a broader package that comes with opportunities and challenges. And I think that one way of summarizing the view is that perhaps to say that there isn't a distinction between Truvada whores and good gay citizens, because sort of some of the things that people have been saying over the last couple of days made me think that the Truvada whores are good gay citizens, in the sense that people want to practice a responsible behavior by protecting themselves against HIV infection and make a contribution to ending this epidemic. I think in some ways it's a sort of almost a complex trigger of sort of bringing to light a range of values that might be conflicting around how do we strategically approach this epidemic, what do we think of the practicalities, what about the economic aspects of it, what about the ethical aspects, which is another argument that's been brought to the fore relatively frequently, sort of in terms of who has access. But there's also the political aspect of it. Can we actually sell PrEP in a broader context? My personal view is that PrEP is a valuable additional tool that can offer real protection. It's going to be of interest, at least what our data show, to a sort of a group of men who are at higher risk of HIV infection. It's a limited group of men for whom it's most relevant, and in that sense it may also sort of have implications for cost, in the sense that might be relatively limited. But I do believe that we have to also think about potential concerns. I'm not that concerned about risk compensation directly by people who use PrEP. I'm much more sort of concerned about the broader movement that we see around sort of people moving to increasingly less effective HIV prevention responses, where PrEP might be sort of at the individual level be a very good response, but I'm not sure what that's going to do at the population level. So for me, it's about moving beyond slogans and beyond dichotomies.
Conversations where there will be less to add each time round that's original, so I'll do my best. And as I was sort of thinking about this earlier on, I was trying to get straight in my head the idea of whether the advent of PrEP was an ordinary or an extraordinary event. Because I suspect that in 10 years' time we'll probably be here and we will conclude that it is useful to some people in some contexts some of the time. And that's exactly the same, actually, as condoms and indeed of negotiated safety, sera sorting, just about everything else that we have discovered in the context of this epidemic. They are useful to some people in some contexts some of the time. And who, when and where is the matter for some discussion, I think. And no doubt in the course of this evening we'll be having some of that discussion. Having said that, PrEP does carry with it a level of anxiety, and certainly for myself it carried a level of anxiety in thinking about this evening, and I tried to work out in my own head again why I was anxious about this. And I came to the conclusion it's probably because there's no public language yet in which we can talk about this with each other, partly because some of the positions that have been taken so far are position taking, either for or against. And as John just suggested a moment ago, what if you are in the middle? Or what if you don't yet have a view about the situation? Are you a legitimate player in the game? Are you actually a legitimate gay man? Are you illegitimate? And I get this funny feeling that to not have a clear view at this moment is to somehow delegitimize oneself and to open oneself up to ridicule, which is deeply worrying, because if we exclude substantial numbers of people from discussion and debate in the context of this epidemic, we've probably lost right from the start, because it's been debate, it's been open discussion and so on that's kept us on course. Having said that, for me the key issues here are to do with social meanings, actually, at the end of the day, and I do think we need to think and debate and discuss with each other some of the meanings that PrEP carries. I mean, what does being prepared for sex in the way of taking PrEP signify? And does it signify the same thing to a young gay man who's just coming out, for example, as to somebody who's more confidently in their middle years, or indeed in their later years of life, as a confident, for example, sexually adventurous man? I mean, are those significations, are those meanings the same? And I suspect they're not, but they do need to be taken into account if we're going to go about actually saying anything about this at all. And what also, echoing something Alan Brotherton said yesterday, how does PrEP frame the other person who is to be protected against? I mean, again, the notion of protection that PrEP implies somehow suggests there are those that who's the we in that sentence? People need to protect themselves against. And does that run the risk of creating a social division, a major division within our communities and within our society? And what about mutuality and PrEP? I mean, one of the key things about most of the strategies we've had to date, which of course, like PrEP itself, is a social strategy, I mean, have been about mutuality. They've been about discussion. They've been about respect. They've been about taking responsibility. And is this actually a mutuality practice? Yes, it could be, but it might not be. It could be a very individualistic practice. You take it secretly at home, or maybe not so secretly at home, or maybe wherever you are. It's just a personal thing. That responsibilization, which will come for some people, could well be an issue. And then finally, I'd say, how do we deal with the controversy within our own communities? The silencing that I felt, that others feel at the moment, and this emerging division between, on the one hand, those who are, and I stereotype now, please don't get annoyed or angry with what I'm about to say. On the one hand, those who are sex positive, young, partying and not partnered, and those who are supposedly sex negative, old, coupled, and sort of not really gay. And there's an argument here about... No, there is an argument here about authenticity of gayness, actually, somewhere in the text, that somehow some men, because they perhaps are partnered or coupled or elderly, are sex negative and not really gay. And anyway, I want to leave it there because there's a whole load of stuff tied up in all of that.
I think I'm going to shift the conversation a little bit and talk about implementation, and kind of talk about the U.S. context of how we've been experiencing kind of the PrEP conversation on the ground, specifically within the gay community in San Francisco. One of my pet projects within the past 2 years has been developing PrEPFacts.org, which you're more than welcome to check on your phone right now if you want to, because it's mobile friendly. But it's this online resource that we built from the San Francisco AIDS Foundation in collaboration with a bunch of different community partners to build a consumer-friendly, keywords, online resource so that people can learn more about PrEP, because we felt in terms of information and kind of the different conversations that people were having, there's a huge information gap, particularly within the U.S. context. We had the FDA approved Truvada for PrEP back in 2010, or no, sorry, IPREX happened in 2010. The FDA approval happened in 2012. And San Francisco was one of the first cities to host a demonstration project. And this was where kind of PrEP kind of came to be. We built the website with the goal not to make sure that everybody got on PrEP, but mostly so they could understand what it was and that they were informed. Because to me, personally, an informed no is just as good as an informed yes on the topic, regardless if you're HIV negative or HIV positive. And with developing the website, we've seen a lot of success with just people coming in from San Francisco and across the globe. And actually within the first month, we had a lot of website traffic from Sydney, which I always find really fascinating. But we had an advertising campaign that was around the city, and we have a bunch of pamphlets that are over on the side tables. But if you look at it, it's like very deliberately non-HIV typical campaign looking. And it has like a 70s porno guy looking on it. It's pink, Pepto-Bismol pink, it's teal. It catches your eye with the intention of making sure that you're like, what is that? Love may have another protector. Like, what does that message mean? You go to the website and then you learn all this information about PrEP. Our experience with just kind of as people are learning more, as people have learned more information about PrEP is that we've seen kind of two waves now within San Francisco, because this is the second year that we've had the website. And the first year, we've noticed that there was this information gap. People just didn't know what PrEP was. They're like, what is this? I don't know what it is. What are the side effects? The condoms dominated the conversation, definitely for sure, around kind of, do I need it? Is it enough? Like, what does it do to my body? How do I get it? And I think as more people learned about it, which we'll take credit for advancing the community conversation, but I feel like there are a bunch of other different factors that happened into it. We saw like a phase 2, as I call it, of reaching the tipping point. Like, there were enough people who learned about it, who understood it, and then they started asking the question, how do I get it? And so then PrEP became this vehicle where we're like, okay, so we need to update the content. We have to figure out, like, how does private health insurance fit into this situation? How do you navigate the process to talk with your doctor? How do you, which, as we all know, it's really hard to talk to your doctor about your sexual orientation and to even have those types of conversations if you're not already having them already. So how do we better inform our constituents on how to have those conversations? So I think one of the things that we did was we then updated PrEP facts to be more relevant to the questions that people were asking, and so developed a bunch of materials to empower people to actually go to their doctor's offices to have those conversations, and have like brochures that people can bring in and walk through with their doctors, like, okay, here are the tests that I need, here's the timetables, this is how much it's going to cost if you're trying to figure out your billing codes, because the U.S. medical care system, as we all know, is a little bit complicated. And so it was more like, with our experience, PrEP has just been such a moving target, and we've tried our best to stay up with the conversation that the community is having, because it's, as more information comes out from all the different research and the demonstration projects and just people's personal experiences that they've been sharing on social media and with each other, it's just been really fascinating to kind of see how people have banded together to just kind of get people more informed and up to speed on kind of what having the sex that they want, and figuring out all the different options that are out there and kind of how it may or may not fit into their lives.
Inviting me to tell a little bit of the story that what is going on in Peru. Peru has a concentrated epidemic in men who have sex with men, and since the year 2000, the gay community and trans community in Peru has been very much involved in enrolling in clinical research, because they want to make a change in what is going on in the epidemic in the country. And the institution for whom I work has been doing clinical research since the year 2000. And in these international clinical trials, most of the enrolled people in these clinical trials came from Peru. Actually, in IPREX, more than 50% of the participants came from Peru. And the thing is that the community is really much engaged in what they want to do for themselves and what to change the way the epidemic is going. But I think that the community at the time that iPrEP started wasn't prepared for success. And what do I mean by that? Prior to iPrEP, there were like 3 other clinical trials that unfortunately didn't succeed. And I think that because of that experience, the community wasn't prepared to have a successful study. And I think that the community at that time wasn't prepared to advocate for the intervention. So what is happening now in the scenario of PrEP in the world is that most of the iPrEP study sites are having and implementing demonstration projects. But unfortunately, the Andean countries weren't able to succeed with demonstration projects in Peru. And then the big question is, how come a study that had most of the participants coming from these Andean countries were not able to access the intervention that was beneficial for them? They got the benefit of the intervention for 72 weeks after the study was over, but once the study was over, the intervention wasn't there anymore. So what happened in this contest? iPrEP and WHO made a lot of effort trying to consult with the community and with stakeholders on how can we work this out, how can we work PrEP as another tool in the toolbox. And unfortunately for the policymakers and other stakeholders, the issue of PrEP and the intervention, the PrEP intervention, was something that was completely new, although there were a lot of efforts trying to educate the community and stakeholders in what PrEP was. The fact that that this new intervention required medication that, first of all, was not licensed in Peru yet, although there is an application from the company that produces the medication. It hasn't been approved in Peru, although there have been 2 applications in the country. So I guess that one of the issues that I see in my country, at least, is how can we do as a community to really organize ourselves to start a new HIV prevention revolution, in terms of can we organize to demand from the regulatory authorities to speed up the process of approval of the medication, and second, how can we make that the AIDS control program could incorporate PrEP as another tool in the toolbox. And the thing is that PrEP is not for everyone. It's for the ones that might decide that they want it or they need it. But at least the community has the possibility of having that and choose for it if they want.
I'm just categorizing what everybody else said. And these derive from my position as a social scientist in looking at PrEP, not just within gay communities, gay male communities, but also work that's been done with women in the United States and injecting drug users, for example, in Thailand. So I'll just draw a little bit from that as well to see if it's informative. So I think the first thing that I would say, and others would say, that's of interest to any of us, but particularly social scientists, is thinking about and understanding that PrEP is not going to be the same for everyone. It's a little bit of what Peter was saying about useful to some people in some contexts some of the time. So we need to think about PrEP as a sort of situated phenomenon, and I think that's really important in the way we approach PrEP. And of course, as you've heard, PrEP has, the way we think in sort of sociological terms is, or in general, is the potentialities of PrEP, that it has, in fact, both positive and negative potentialities, a little bit of the binary that we're trying to resist, but it's a useful way for thinking about what PrEP offers and what PrEP offers both positively and perhaps negatively. So on the positive realm, just to give some specificity to what we've been talking about, this is a highly efficacious prevention strategy if it's used correctly and consistently. So we've got this highly efficacious option, which is a nice thing. PrEP also has the ability, it confers on the individual at least, the ability to control its use. So there's agency that one can exercise in the use of PrEP, and that includes the stealth factor. So you might want to be taking PrEP in a situation where you don't want your partner to know that you're using something preventive. For women, this is this women-controlled method that we've been talking around microbicides for a number of years. This can be applied to PrEP as well. And importantly, it's not coitally dependent, at least at this point. And so this is a strategy that can be taken and used consistently, pill a day, whether or not you're having sex, and not necessarily right before or right after sex. And soon we'll have different options, not just an oral administration of a pill a day, but we may have injectable PrEP, and we may have, for women, intravaginal rings. Those are, in fact, under study right now. So having options and choices for individuals who might choose to take PrEP in some context, some of the time. So those are some of the positives. The negatives, or potential negatives, that I think we've heard about, one category I would use is, or one way to characterize some of these, is the substitutive nature of PrEP. And this makes people very nervous. The idea that PrEP might substitute for condom use. And within gay communities in particular, condoms have kind of been reified to a certain extent, but have achieved this very important status as a kind of a comfort, as Colin was mentioned early in his comments. So supplanting condom use is actually a very dangerous thing in many people's minds, or it's very threatening. It does create a lot of anxieties. Other groups, like injecting drug users, fear and have some kind of reasonable, have some good reason to fear the possibility that in societies and cultures, not just because of constrained budgets, but also the politics thereof, having PrEP available might allow entities to supersede other kinds of prevention strategies, like the provision of methadone maintenance for injectors, other harm reduction strategies. And so it might allow states to say, we're going to offer this drug or make that available, and not anymore provide these kind of harm reduction strategies. And that's been heard from tie injecting drug users, for example. And I think, some people fear, some women feel that PrEP might allow men to sort of get off the hook with condom use, where they think condom use is still something that should be regular amongst men in heterosexual partnerships. So there's that sort of fear of the substitutive nature of PrEP. There's also potentiality for a coercive aspect of PrEP use to emerge, where people feel like they have to take it, whether or not they actually want to take it. And that's been already expressed by some sex workers who are fearful that there may be a kind of requirement that, or an expectation that PrEP is used. And again, sort of getting men off the hook for condom use at the same time. And in some individual cases in relational context, perhaps partners might demand that their other partners use PrEP. Another sort of category of the potential negative aspects of PrEP is the possibility of it potentiating this new sex moralism, which I think you've heard a fair bit about, and that's the whole Truvada whore and the appropriation of the Truvada whore by men who are on Truvada itself and for PrEP. But this possibility of shaming people around their sexual activity, and the sort of randy gay man frame. I think it was interesting for me to hear Peter say, what does it mean for men to be prepared for sex? This sounds very familiar to heterosexual women who've had to contracept all their lives. And when initially oral contraception emerged, that was precisely the question of, and I think a lot of women personally asked that, am I a whore, basically, because I'm being prepared for sex under any circumstance? So that's just my opportunity to say there are a lot of analogies around oral contraception with PrEP that may not be firsthand for gay men who haven't had to contracept all their lives, but come easily to women. And I think the final one I'll mention is stigma, the possibility of HIV stigma. Anybody using antiretrovirals does harbor some fear about the identification with HIV positivity and taking drugs for that purpose. And I think we don't want to lose sight that possibility does still exist. So I think I can leave it at that, and we'll talk about some of the other issues, obviously cost and payment and the kinds of structural issues that John mentioned are obviously also important. So thank you.